Welcome to Cannabis 101. I don't have any relevant financial disclosures. Over the next 20 minutes, I will discuss the prevalence of cannabis use, the reported reasons for therapeutic and recreational cannabis use, the diversity of U.S. state laws for therapeutic and recreational cannabis use, cannabis pharmacology and routes of administration, cannabis risks, side effects, and impact on work performance. Cannabis has been in use for centuries. Its first reported use was in 4000 BC in China. It was used with the Greco-Roman era, 450 to 200 BC, and it was reportedly used for the treatment of epilepsy between the years 1000 and 1400 AD. In 1850, it entered the U.S. pharmacopoeia as a treatment for neuralgia, opioid addiction, and alcoholism. However, due to the opioid and drug crisis in the early 1900s, which included marijuana, it was federally prohibited as part of the Marijuana Tax Act in 1937, and in 1942 it was removed from the U.S. pharmacopoeia. It wasn't until 1964 that THC, which is the psychoactive component of cannabis, was even discovered. And in 1970, as part of the Controlled Substance Act, which regulated drugs or medications that may have addictive or properties, it became a Scheduled 1, the same class that you would see heroin or LSD, no therapeutic purposes. And recreational use led to increased criminalization. It wasn't until 1988 that we even discovered the CBD1 and 2 receptors, which we'll talk about a little bit later. But from 2000 on, there has been increased therapeutic use and an increased push for legalization. According to the National Survey on Drug Use and Health from 2023, U.S. people ages 12 or older, greater than 61 million reported marijuana use in the last year. And people use cannabis for a variety of reasons. According to surveillance data, about 38% use it just for recreational use, about a third for recreational medical use, and about 29% for medical use only. Young adults report using cannabis for enjoyment and fun, to conform with friends, to experiment, to enhance their social situation, and to relax. College students report using cannabis again for social facilitation, to be accepted by peers, to treat emotional pain, and for sex seeking. In a small Canadian study of long-term users, the top reason for cannabis use was relaxation. Other reasons include feeling good, enjoying media, medical use, inspiration, depression, anxiety, better sleep, and to treat boredom. People also use cannabis to self-treat symptoms. In a 2018 online survey from the US and Canada, over 27,000 respondents, 27% of these reported symptom management use. There was higher use in legal states versus illegal use states. And among the reported reasons for symptom management use were pain, sleep, headache, nausea, vomiting, appetite, anxiety, depression, post-traumatic stress disorder, substance use disorder, psychosis. In our own study, in our palliative care clinic, where about 30% of people with cancer reported using cannabis, many of the same reasons for cannabis use emerged: pain, sleep, appetite, nausea, vomiting, anxiety. In the United States, cannabis is federally illegal, but state cannabis policies are variable and changing. On this map, the states in black, cannabis is legal both recreationally and therapeutically. In the green states, it's medically available and decriminalized. Only in 4 states is it fully illegal, and in a handful of states in gray, CBD with low THC content is legal. And the majority of Americans now support the legalization of marijuana, whereas in 1969, only 12% of Americans supported the legalization of marijuana. In 2019, 67% supported legalization. And in terms of should be legal, 59% reported it should be legal for medical and recreational use, and 32% for medical use only, with less than 10% saying it shouldn't be legal. And it's interesting when you look at the demographics that even in those age 65 and older, almost half reported it should be legal for medical and recreational use. So the attitudes have changed dramatically over the last 50 years. What do we know about cannabis? Cannabis contains greater than 100 phytocannabinoids and greater than 600 chemical constituents. The two most prevalent cannabinoids that we know about are delta-9 tetrahydrocannabinol, that's THC. This is the psychoactive component of cannabis. It's also been studied for nausea, for pain, and appetite stimulation. And as I said before, it was discovered in 1964. Cannabidiol is not psychoactive, but has been studied in terms of its treatment for seizures, anxiety, and anti-inflammatory. There are less studied cannabinoids and terpenes that may contribute to cannabis's effect, but we don't fully understand that at this point. The challenge is that there's no standardization. There's diverse strains of cannabis that are bred and available. And whereas in the 1970s, in a typical marijuana plant, there'd be 3 to 5% THC concentration. Nowadays, one could go to a dispensary and get vape products with greater than 94% THC. And there are low THC, high CBD products, and intermediate blends. And the challenge is there's no standardization, so it's very difficult to be able to fully understand and study. The endogenous cannabinoid system wasn't discovered until 1988 in terms of the cannabidiol 1 and cannabidiol 2 receptors. The cannabidiol 1 receptors is primarily in our nervous system, whereas the cannabidiol 2 receptors in an immune system. And their role is in the pain regulation, mood modulation, including reward, cognition, learning, memory, energy balance, and appetite. What we don't know, though, is what is the effect of exogenous cannabinoids, like when we take in THC and CBD? What is it effect on our endogenous cannabinoid system, especially over time? There are only 3 pharmaceutical cannabis products available in the United States. The first 2 became available in 1985 that were synthetic THC products to treat appetite loss secondary to HIV disease and chemotherapy-induced nausea and vomiting. The first CBD product became available in 2018 to treat seizures secondary to Lennox-Gastaut or Dravet syndrome. There is a 1-to-1 THC CBD product that's used to treat multiple sclerosis spasticity and off-label to treat neuropathic pain that's available in more than 27 countries, but it's not approved in the United States. CBD became widely available after 2018 when the U.S. Farm Bill was amended and exempted hemp, which had less than 0.3% THC products, from the marijuana prohibition. So all of a sudden, you saw all these CBD products available online, in drugstores, and gas stations for reported uses to treat anxiety, depression, cancer, epilepsy. The challenge is that 58 of 84 samples of CBD that were purchased online in a study done by Bond and Miller had mislabeled CBD content. Some did not have CBD at all. Some had higher THC content than was allowed, or no THC content was on the label, but it had that. So we have to be careful about what patients are getting. And so the marketing indications have not been well studied. What does the evidence show about cannabis therapeutic effects? The cannabis evidence of effects is so difficult to accurately determine. The THC content in studies is really lower than patients are utilizing because they were even using the FDA formulations that we talked about, or you could get in the United States cannabis from one place to be used in studies where the THC content is much lower than when patients are using. There was a lot of diversity of study. There's a lot of opinion bias and industry influence, especially in the push for legalization. And there's changing evidence over the time. So this has created research and clinical challenges. According to the National Academy for Science, Engineering, and Medicine, there is substantial or conclusive evidence to treat chronic pain in adults, particularly neuropathic pain, chemotherapy-induced nausea and vomiting, subjective spasticity secondary to multiple sclerosis, and certain forms of epilepsy. There's some moderate evidence for short-term sleep. There's very limited evidence for appetite and weight loss, anxiety symptoms, post-traumatic stress disorder symptoms, and dementia, and absolutely insufficient evidence for the treatment of cancer cachexia, cancer, neurodegenerative diseases, irritable bowel syndrome, or abstinence from drugs. CBD may have efficacy for some symptoms such as anxiety, insomnia, addiction, and mood, but high-quality studies are lacking. There were some trials that suggested that CBD may be effective for some anxiety, but most of these studies were conducted in healthy males for social anxiety disorder. There's been some preclinical, small clinical trials and anecdotal evidence for the treatment of the other conditions. However, there's unclear side effects of CBD use due to the lack of studies. The take home is that even though evidence is lacking, people are experimenting with the use of CBD for these conditions. There are many different formulations of cannabis. In the smoke or vape products, there's a rapid onset of action, 5 to 10 minutes, with a duration of action for 2 to 4 hours. In terms of edible products, it has a slower onset of action, which can be anywhere from 1 to 3 hours, and the duration of action can be to 6 to 8 hours. While transmucosal or sublingual products may have a quicker onset of action, 15 to 45 minutes, they still can have a duration of action of 6 to 8 hours. In terms of transdermal or topical, there's variable onset and duration, and THC is highly lipophilic, so it can be absorbed into the fat cells, but again, we do not know the duration of action. When we think about testing for cannabis and urine drug testing, the detection of THC in urine varies. There's nothing I know of in terms of urine drug test at this point to test for CBD, but for THC, if someone used cannabis once, it could be detected 3 days later. For those using it 4 times a week, it might be able to be detected 1 week later. For chronic use, up to half a month. And for a chronic heavy smoker, it may be in the urine detectable for greater than 30 days. In terms of people that are testing it for work performance or work use, there are some other tests like a saliva that may be able to test for more recent use. What are the adverse effects or potential harms of cannabis use? Reported THC effects, many have to do with central nervous system effects, drowsiness, dizziness, confusion, mental clouding, and slurred speech. But physically, there have been reports of tachycardia and hypotension, nausea, fatigue, dry mouth, and something called cannabis hyperemesis syndrome, where the use of cannabis causes this condition of vomiting that will only resolve in the short term with hot showers, in the long term by ceasing cannabis use. CBD also has adverse effects, although they've been less studied except for the FDA-approved Epidiolex for seizures. But reported adverse effects include drowsiness and sedation, mood changes, interactions with prescription medications that may affect actions and can cause toxicity, liver toxicity, reproductive and developmental effects. And the real take home is that people are using CBD. It's over the counter. They can get it anywhere. It's reported safe. I most worry about the clinical effects it may have when we're thinking about drug-drug interactions for people that are on prescription medications, say to treat mood. We would need to look at how much is that clinical relevance in terms of these interactions. The potential harms of cannabis use have also been reported secondary to prenatal developmental changes, some developmental changes in adolescence in terms of intellect, motivational, and maturation. There have been some studies that show a significant correlation between high THC blood concentrations and car crash risks. And there have been mixed effects in terms of blood pressure, but there's some limited evidence that cannabis use could trigger a myocardial infarction, a stroke, or exacerbate COPD. And cannabis may affect work performance. High quality studies evaluating the effect of medical cannabis on workplace performance are lacking, but we have to think about the reported adverse effects of THC, such as sedation, nausea, vomiting, dizziness, and euphoria, could be associated with performance. A Canadian study showed a twofold increase of injury risk for workplace cannabis use, but none for non-workplace use. However, in a case-controlled study of recreational marijuana legalization and workplace injuries in younger workers, in those places where there was recreational legalization adoption, there was an 8.4% increase in injury. In susceptible individuals, there's potential mental harms of cannabis, which increase risk of psychotic disorders, anxiety disorders, bipolar, suicidal ideation, and there is a risk of the development of cannabis use disorder in about 30% of recreational users. And according to the National Survey on Drug Use and Health, there were 16.6% of cannabis users 18 to 25 that had a disorder. And how can this affect work? In one study, it showed that the severity of cannabis use disorder was associated with increased absenteeism. The higher the severity of the cannabis use disorder, the higher rates of absenteeism. So some takeaway considerations is that cannabis use is very common in the U.S. and that people use cannabis for diverse reasons, whether recreationally or therapeutically. And the laws and regulations are variable at state levels, but that cannabis can impact individual well-being, work performance, and work safety. Included are some selective references for this presentation, and I thank you for your attention.